Welcome back to another episode of Clinicians Brief, the podcast. Your behind-the-scenes pass to the conversations behind all of your favorite Clinicians Brief content. I'm the host of this show, Dr. Alyssa Watson, and I am absolutely delighted to reintroduce one of our esteemed guests and favorite authors, Dr. Karen Tobias. Dr. Tobias is a professor of small animal soft tissue surgery, as well as a surgeon at the University of Tennessee. She's previously joined us on this show to explore such intriguing topics as the optimal gonadectomy timing in dogs, as well as crafting a coaptation device for elbow hygromas out of a pool noodle. That was one of my favorite episodes, super fun. I got to do some DIY crafting. So if you haven't had a chance to explore those discussions, I highly recommend that you look back through and give them a listen. And today's conversation promises to be equally as engaging and enlightening because we're going to delve into a case of post-grooming furunculosis in a 13-month-old intact female Pembroke Welsh Corgi. The inspiration for this episode stems from an article that Dr. Tobias co-authored, and that is available on our website at www.cliniciansbrief.com. But let's, Dr. Tobias, why don't you, for anybody that hasn't listened to your previous episodes, which is not very many, because I'll tell you they're some of our most popular, absolutely. But if you could just quick run through your bio again, that would be great.
Well, I'm here at University of Tennessee in the soft tissue surgery section, and I've been here for over 20 years now. So that's most of my bio, really. I'm an institute professor now, which means I've just been here a long time, but planning on being here some more years as well, because it's a great place.
I'm so glad. Let's talk about this case. So just walk the audience through like how this case presented, because the presenting clinical signs kind of led to a presumptive diagnosis that was incorrect at first. And then we'll walk through, we'll kind of walk through it with you, how we arrived at the actual diagnosis.
Sure. Yeah. Ella was being fostered by her owner. Her original owner had surrendered her because of behavioral issues. So that kind of threw a little wrench in things because she didn't really like coming to the veterinary hospital. And she was scheduled to come to us for an ovarian hysterectomy. And about 3 or 4 days before she was scheduled to come in, she was groomed, got her bath and everything, so she'd be all pretty for her visit. But at about 3 days before presentation, she progressively became a little bit more lethargic. She started to lose her appetite. And when she came into us, she was anxious, which we expected because that was her personality. So that didn't really surprise us that she had 103 temperature, but she was also tachycardic, when that could have been her stress. But then we tried to do a physical exam on her, and she started screaming in pain. And that really occurred when we started palpating around her neck. And so that was the biggest thing that scared us, was this really severe pain on palpation and manipulation of her neck. So the first thing I did, of course, was run down the hallway and get the neurologist and say, I don't know what to do, but this dog looks really bad.
Yeah, I'll tell you, that is one thing that I really struggle with in clinical practice, is when I have a patient that presents with a problem, lethargy, or just, we call it ADR, ain't doing right, and then they have that fever that's like 103, but I'll also see 103 right in my, really excited or nervous animals that come in totally fine just for vaccines. And so it can be really hard, to distinguish, what do we do with that information? Is that truly a fever or not? So,
right, I agree. And especially if you have a dog that also doesn't necessarily have the friendliest personality in the hospital. Now they're trying to bite you. And so are we really finding pain or not? And that's why I wanted to get somebody else who manipulates necks all the time.
Mm-hmm. So you did get the neurology consult, and that led she's got a whole team now of wonderful veterinarians, and that led this team to suspect acute steroid responsive meningitis arteritis. And in order to pursue that diagnosis, she was scheduled for a spinal tap. So how did that help, further her diagnosis? What happened next?
I think probably the most important thing that did to further her diagnosis was we anesthetized her so we could actually handle her. And that allowed us to do a more thorough physical exam. And I think that's kind of an important thing. If you have an animal
Mhm.
where you can't do a thorough physical exam, maybe you do need to use some heavy sedation just to be able to look at things. And so we were looking for an area where we could clip her to do the CSF tap. And that's when we started noticing that right on her dorsal midline, she had these scabs and these little erythematous regions and these draining tracts, and we couldn't see that before with her really thick coat. And so we clipped up an area and saw these terrible lesions that were hidden by this very thick undercoat.
Certainly. So, once you did discover those, can I ask what was your next step? Did you actually continue to clip all of the skin to uncover all the extent of those lesions, or were you worried about that causing? Sometimes we worry about clipping causing microexcoriations and more trauma and spread of infection. So, I was interested in what that next step was.
Well, my next step was to run down the hallway to the
To the
dermatologist
dermatologist.
and say, there's this dog and it's got this really weird thing and I don't know what it was. And can you come and just take a quick peek? Because she's under anesthesia and I just seriously have never seen anything like this. And so immediately now we have our dermatology specialists involved and they looked at it, heard the history and said, nah, this is the answer. This is going to be postgrooming furunculosis. And I automatically said, what is that? I'd never heard of it ever. And no, we definitely did not clip anymore because just as you say, it's probably happening because of skin trauma. And so we don't want to traumatize the area anymore. We did clip a little bit and that gave us an ability to do some sampling.
Okay. And I'm going to assume that the spinal tap was canceled.
The spinal tap was not canceled.
Was not.
We went ahead and got that as well because we were very, very thorough.
Mm-hmm.
And there was a little bit of inflammation actually
Hmm.
within that spinal tap. So it was kind of interesting that she had a few of those changes as well. But really, everything could have been simply because of this furunculosis that they
Mm-hmm.
get with grooming.
Could you talk just a little bit about any added risks when you are performing a spinal tap on an animal that has obvious skin lesions and infection, and how that changed maybe your prepping for that procedure?
Our goal was to try and do a caudal tap because up around the neck she had more lesions, and so we wanted to enter in a clean area. If she hadn't had an area where the skin wasn't disrupted, if we didn't have normal skin, we wouldn't have tried the CSF tap. But it was just it was a very interesting case for me.
Yeah.
I had no idea what I was looking at, so it's kind of nice actually to get all of this information. And being a teaching hospital, I think we all learned a lot from all of those.
Yeah, I think it's great. In the article, there is a nice table, that lists out some of the abnormalities which were found on her lab work, including a very elevated white blood cell count, neutrophilia, as well as some other things. I was very intrigued by the inclusion of C-reactive protein in her diagnostics. So, um, personally, I have never used C-reactive protein in my veterinary patients, but I am familiar with it because my own son, when he was very young, 3 years old, he was diagnosed with Kawasaki disease, which is an immune-mediated arteritis. It's pretty rare. And actually, I had wonderful colleagues and friends through the veterinary moms group who had also had children diagnosed that really were very supportive of me and helped kind of guide to that diagnosis and for me to be an advocate for my son and really get to that diagnosis. But they watched his C-reactive protein like a hawk for over a year after he was fully recovered. So what are acute phase proteins, and where are they produced in the body? Can you walk us through that?
Sure. Now, this is definitely not something that a surgeon studies quite as often as the internal medicine folks do. But an acute phase protein is going to be something that changes at least 25% when you have serious inflammation. And so it could go up or down. Most of the ones that we think about go up. But I think the classic one that goes down would be albumin. So
Mhm.
when you see an animal that has developed severe systemic inflammation, their albumin tends to go down 72 to 96 hours afterwards. But many of these will go up, and it really depends on the species. For instance, in dogs, the C reactive protein is the one that we'll use the most. And we'll see that change about tenfold in a dog that has very acute inflammation. And it'll actually change before white blood cells change. And so I think our medicine folks probably use it a lot more than the surgeons do. But what it'll do is it'll tell us something's coming down the line, there's severe inflammation, there's some sort of tissue reaction that's going on, and you need to be looking for that. Or in an animal where you've diagnosed some issue, where there's an inflammatory problem, you can use that C-reactive protein to see, are they responding to treatment? Because it goes down very quickly compared to white blood cells and compared to the albumin going back up. And you can also see early on if they are having a relapse. And so while it's not really very specific, it is a very sensitive indicator that there's some sort of really major inflammation going on.
Exactly. And so that was kind of the next thing that I was looking at. Just as you said, they increase, with anything that causes inflammation. So that could be trauma, that could be infection, that could be cancer, but really, unfortunately, do lack that specificity. So are you, in the university setting, are you using them more diagnostically, or, like you said, more tracking treatment?
I think that when we see the C reactive proteins go up really, really high,
Hmm.
then we suspect either an immune mediated problem or a bacterial problem. And so
Okay.
that's helpful because it kind of points us in that direction, particularly since it changes before white blood cells do. And it is now included on all of our chemistry panels so that it can be used to monitor because of the fact that we see many animals that might have chronic inflammatory problems. And we can see if there's a spike again, we've got to look for a relapse, we've got to look for a persistent infection or something like that. And in Ella's case, we actually measured it probably 3 or 4 days after she had the first incidence of massive inflammation, and it was still more than 10 times normal. And
Hmm.
that's at the time period where it's actually coming down. So it was quite impressive how high it was.
Yeah, it could go very, very high.
Yes. And
So, and actually, Ella, you had mentioned albumin, as another indicator, and that one you said tends to go to decrease instead. And Ella's albumin was decreased a little bit, I had noticed.
yes, it
Um,
was. And that also tells us that we were a little farther down the line because usually the albumin drops like day 3 or 4.
mhm.
And at least when experimentally, when it's been measured, that's what'll happen. So hers did drop, and she did have an increase in her white blood cell count at all. It was a mature change, so either acute inflammation or stress, but hard to tell with her. It could have been stress.
So you mentioned that different species, have these different acute phase proteins that are very useful. Besides the C-reactive protein, what other ones are we looking at for dogs and cats? And I know there's some for horses too, but I don't know which one.
Yeah, I'm actually not familiar with how often they
Mhm.
measure the acute phase proteins in cats and in horses and other species.
Mhm.
And in cats, it's a like serum amyloid A, and I think that there are now more automated assays for it, but it's not something that we consistently measure here, as far as I know. Again, it's a little bit
Mhm.
outside of my
Yeah,
specialty.
absolutely. Do you happen to know if those are becoming more available in general practice? Certainly the C-reactive protein, I didn't know this until, I read your article and until I started doing, my homework for this episode, but there are definitely some commercial diagnostic labs that are running that. And like you said, you do it on all of your, chemistry panels that you're running. What about, do you know, are there any, point of care tabletop tests coming down the line?
I don't know about that. No,
Okay.
I would expect that if you could send it away to one of the major companies, you could probably get it. But I don't really know too much about the tabletop tests.
No worries. It's something we'll have to look into. For veterinary teams, time is always in short supply. Enter Plums Pro, the revolutionary all-in-one clinical support tool on a powerful, easy-to-use digital platform. With Plums Pro, you'll find hundreds of peer-reviewed clinical briefs and algorithms to help you work up cases with confidence, along with a library of shareable guides for pet owners to help them feel more confident too. And of course, you'll find accurate, continually updated drug information and tools, including the groundbreaking new drug interaction checker. Visit plums.com to see how the next generation of Plums will change the way you work. So let's move on to a little bit more diagnostics as well as treatment for Ellie's case. They cultured, you said you clipped enough to get some samples. So I'm assuming they did some sin scrapes and looked under the microscope as well as did some culturing. And they did end up culturing Pseudomonas aeruginosa.
Yeah.
So is this the only bacteria that's known to cause this condition, this post-grooming furunculosis?
I think it's the most common bacteria that's reported, but there have been other bacteria that have been reported either together with Pseudomonas or alone, like Staphylococcus and Serratia have been reported. The difficulty is that there just aren't that many papers out on this condition. And for me, that's why it was so surprising for a dermatologist to look at it and say, oh yeah, I know exactly what that is, because I wish people would be doing more research on it. But in some of the papers, besides Pseudomonas, they did see a variety of bacteria. So I imagine that some of these animals can get secondary infections as well. If you have an animal that has a Pseudomonas infection, it probably does set them up for other things like the staph concurrently.
And Pseudomonas has some kind of specific characteristics that make it one of the most common pathogens for this condition, namely that I think it really likes water, right?
Yes, it likes warm, moist, humid environments. So when there have been outbreaks of not post-grooming furunculosis, but outbreaks of Pseudomonas furunculosis in people, it's usually been around hot tubs and swimming pools and stuff like that. So I think that makes it obvious why it might be grooming facilities where you would see it more often, because you've definitely got a warm, moist environment. And then I think Pseudomonas has some individual characteristics, like it can produce this slime, so that's probably harder for the animal to fight off the infection. And it also has these little things on it that allow it to adhere better to skin cells. But most of the time, we're just going to see it in ear infections. And so to see it as the sole cause of a skin infection, that's where you have to start thinking of something like this condition, where there's been some sort of inciting cause, like grooming, that will set the animal up for the infection.
Absolutely. Like we were talking about those microexcoriations and trauma, and we'll talk a bit more about it later, but even, just vigorous rubbing, I have heard can cause trauma to the skin. So, also coat type, I think, is one of the things that, are there specific breeds or coat types that are predisposed to this condition?
Yeah, and I think, again, because there aren't that many papers out there, and because the papers that were done really didn't compare to hospital populations, that makes it a little bit difficult to know if you're dealing with a specific breed. But I think German Shepherds are one of the top breeds that are listed. One of the papers listed Labradors and Goldens, but they're so popular. If you don't compare that to hospital population, you don't know, is it more common? And then one of the papers listed Welsh Corgis. So in my mind, I think of those dogs that have a really, really dense fur coat. And is it that predisposes them? Or is it that the grooming techniques predispose them? Or is it that you can't see the infection, and so you let it go a little while? I'm not really sure.
Yeah, those are all really good questions. And it kind of reminds me a little bit about our conversation on gonadectomy timing, where we were talking about mammary cancer. We were talking about risk versus relative risk, and when you're talking about a big population versus, very few cases, it can be really hard to pin down, what are those inciting causes.
Yeah, I agree. And I think that's where it would be great to have a group that is collecting cases so that we can get more than 20 at a time, which is
Mhm.
probably the highest number that's been reported. I mean, if this is really that common, and I didn't know, but must be pretty common when people look at it and say they know what it is, we ought to be able to collect 100 cases amongst all of us and put it together and find out what breed and things like that.
Huh. Well, certainly in today's day and age, antimicrobial stewardship is always, top, very high priority at the forefront of conversation. But obviously, this is a bacterial infection, so antibiotics are going to be, critical when treating this condition. What are the recommended first choice while we're waiting for things like culture and sensitivity, which we know can take a couple days?
Yes, I think that fluoroquinolone is going to be your best choice. And so the tricky thing is that this is a bacteria that can develop acquired resistance pretty easily. And so if the animal's been on antibiotics before, that could affect what it's going to be sensitive to. However, for most of these animals, they're going to be sensitive to marbofloxacin or enrofloxacin, a once a day treatment. And you should see improvement in these dogs really quickly, like 24 to 48 hours with analgesics and antibiotics, and they should get better.
That was actually going to be my next question with the fluoroquinolones, because we do know they're that dose dependent, not time above MIC dependent
Right.
antibiotics. So you want to hit them once a day and at the highest dose that they can tolerate. Sometimes they can be hard on the tummy and things like that. So do you have any advice on that?
I can say that what's recommended in the literature is not as high as I've gone for some types of Pseudomonas. So for the marbofloxacin, one of the papers said 3.7 to 6.3 milligrams per kilogram once a day. And for the enrofloxacin, they were using 10 to 12 milligrams per kilogram once a day as well. And I've certainly seen people use higher doses. So to me, that was comforting to know that I didn't have to max them out on the dose and therefore cause some of those GI issues. And then the other thing that you could consider is if you've had an animal that's been on fluoroquinolones before, let's say that it's a dog that's had otitis and you've had them on those. Some of these are sensitive to trimethoprim sulfadiazine. And so that would be another potential first choice because we usually have that on our countertop as well as these other fluoroquinolones.
Yep. That's a good one. Potentiated sulfas, though, can sometimes I have personal bad experience with potentiated sulfas and polyarthritis. So
Yeah,
in my own dog, so
yeah,
I'm biased. I don't like them.
yeah. And it may be dose related, it may be duration of action,
Mhm.
it may be the breed, but
Yeah, yeah.
if
It was
you're
probably
using
the breed. She was a Great Dane. So, um, there also, I mean, as you noted, the whole presentation of this case, this dog was incredibly painful. So painful, that you got a neurologist in there stat. So we needed analgesia. In addition to antibiotics to treat the infection, what type of analgesia therapy was used in this case?
because we went ahead and treated her with steroids just in case, since she did have mild inflammation on her CSF tap, and
Mhm.
because we're not afraid to use steroids when they have Pseudomonas infections, if we think getting down the inflammation will have better antibiotic delivery, that meant that we couldn't use the traditional NSAIDs, carprofen, and things like that. And so we went ahead and used acetaminophen as our major analgesic, and that is used so very commonly in England. It's
Mhm.
amazing that that's their go-to drug if you can't use some sort of nonsteroidal anti-inflammatory.
Mhm. Yeah, I'll tell you. I do a lot of palliative care. So I'm only in general practice, a few shifts a month these days. Primarily, I do in-home end-of-life services and a little bit of hospice care, if people aren't quite ready to say goodbye. And I use a ton of acetaminophen,
Good.
either alone or with codeine. But I do find, especially on Facebook groups and things like that, there is a lot of confusion in the veterinary community around the safety of acetaminophen in dogs. So I know you said they use it in Europe all the time. Can you just talk to that a little bit? And certainly we know there is a big distinction between dogs and cats using this drug.
Right. That's good to mention that we don't use it at all in cats because it's a very narrow window of safety. So in Ella's case, we did use acetaminophen plus codeine because that's what we prescribe in our pharmacy. But our pharmacy now is carrying pure acetaminophen because the bioavailability of codeine is pretty low. And also, some of the analgesia studies have shown that codeine doesn't add anything in terms of analgesia, which is kind of a surprise. So maybe it just people respond differently than dogs do and stuff like that. So maybe that might take out some of the narcotic effects that we might see from the codeine, the dysphoria and stuff like that. So the thing about acetaminophen, and in Europe, it's called by the other generic name, which is paracetamol. I think is
Paracetamol, I believe.
there we
Yeah.
go. Good. Yeah, and that has been studied a lot in terms of analgesics. And in ovariohysterectomies, it's very similar to our traditional NSAIDs. And in orthopedic cases, it can be added on top of other medications and provide additional analgesia. And there have been a lot of toxicity studies in dogs, and the toxic dose is greater than 200 milligrams per kilogram. So probably just like our nonsteroidal anti-inflammatory drugs, there are individual dogs who that may have some sort of reaction to it that just don't have the right enzymes to process it through the liver. But for the most part, most dogs are able to handle acetaminophen very well, and the toxic dose is very, very high compared to what we use clinically.
Okay. So because you are a surgeon, are you using acetaminophen post-op in routine cases like ovariohysterectomy and, orthopedic procedures?
We do use it depending on the animal's condition and what other drugs they're on. So any animal that's had steroids, we obviously can't give them carprofen or meloxicam or
Mhm.
Duramax or any of those. And so we need to have something else that we can add on to. And I think people set a lot of store in gabapentin, but since it really gets neurogenic pain, it may not get other types of pain, and maybe it has more sedation than analgesia in some cases. It's nice to add something else on top of that. So for my routine ovariohysterectomies and castrations, I usually give an injectable NSAID because I can get it into them before they wake up, and now they've got a dose for 12 hours, and then we can send them home on something oral. So we'll continue the same thing. For animals that are on steroids, definitely use acetaminophen, and that's my go-to drug. And then if I need to add something else on top of that, I think multimodal. What else can I use? Is gabapentin going to be sufficient on top of that? Do they need oral buprenorphine, a fentanyl patch, or something like that? Thinking of other options. I think the tricky thing is when you have a small patient, because the smallest acetaminophen unflavored tablet is 325 milligrams. And so if you're going with a 10 to 15 milligram per kilogram dose, then a little 1 kilogram dog only needs 10 milligrams. So what do we do with that? And so you just have to be real careful if you go for the liquid versions, the flavored versions, to make sure they don't have xylitol. And most of the ones that you find with the brand names, like children's Tylenol,
Mhm.
that is actually flavored with sucralose and sorbitol. And both of those can be used in dogs. And that comes at 32 milligrams per mil. So it's a little bit easier to dose. You just got to make sure that they're, I don't know what the toxic dose of xylitol is or how much is in those flavored ones that have xylitol. They don't tell you that concentration. So you just look for something that doesn't have it.
Absolutely. Better to be to be safe. Excuse me. We have a clinician's brief article on a dog that ate a whole bottle of melatonin and ended up with xylitol toxicosis because didn't have a problem with the melatonin, but they were strawberry flavored tablets or something like that. And so absolutely can happen. I'm pretty sure it'd be interesting to see what happens because I'm pretty sure paracetamol in Europe, it has an injectable form. And I know there's an injectable acetaminophen too, because they gave it to my son because he was throwing up everything and couldn't take anything orally. But it was so expensive, I'm pretty sure. Yeah. So maybe in the future, if those things come down in price.
There was one IV study on acetaminophen for analgesia after a spay, and it didn't work as well. So as well as carprofen and stuff like that. So I don't know if they're going to have to fool around with the dosages or what the difference is, but definitely there is some information of that out there, and maybe it'll be something we can add on top, particularly in a dog that's on steroids.
Yeah, because like you said, for a while it was tramadol, and then it was GABA, and now they're saying, well, that might not be the best either, and so we're back to NSAIDs and steroids.
Exactly.
It all comes full circle.
It does.
So we'll get back to this case. I wanted to talk about length of treatment because this is really important. This was something that my dermatologist at Iowa State always hammered into us that, when you've got deep infection in the skin, it takes 3 weeks for the skin to turn over and you want to be treating all the way through that. So what is the typical length of treatment, when we're talking about a condition like post-grooming furunculosis?
I think that what I've read about the dermatologist comments anyway are to continue treatment for at least 2 weeks after the clinical signs have resolved. I think that unfortunately we just don't have the research to know whether or not that's absolutely necessary, or if you stop traumatizing and you let the areas around the follicles heal, then maybe that will improve the animals. Because there was one paper where one dog only received 4 weeks of steroids and that completely cleared up the condition. So do you really need to treat for that long with antibiotics? And in people, the treatment for peritonitis is now 3 to 5 days, which is blow my mind, right?
So UTIs too completely changed in the last 20 years since I went to school.
Right. So that theory of, we have to wait until there's cell turnover. Do we really? I don't know. I'm not a dermatologist, but I suspect we're not going to have to treat for 3 or 4 or 5 weeks, especially if they're getting better in 2 to 3 days.
Excellent. Well, finally, we'll talk about some suggested preventive measures. So in order to decrease the likelihood of this, there's lots of things, we talked about that whole vigorous rubbing. That was another practice that I had heard can help. Always make sure you're rubbing in the direction of the hair follicle, not, vigorously rubbing against the direction of the hair coat, because that can, push those hair follicles, up in and cause more trauma. But there was something that I had not encountered before, and that was to not use diluted shampoos and conditioners. And this is something that I take my own dogs to, those self-wash facilities, because I don't want to clean all the hair out of, my drain. So I take them to the self-wash, and they all have, these shampoos lined up that you can use, but they are definitely, a quarter shampoo diluted in 3/4 of water. So what is the problem with that?
Again, there's no research proof for what specifically is the problem. So the things that are hypothesized is one, that if you dilute it down so that it makes it an okay environment for the bacteria to hang around in, then maybe that's the issue, is you don't have high enough concentrations, and so more bacteria are able to be there. But I think also things that you have to think about, one is, how did the bottle get contaminated? If it was a first time use and it got contaminated, then it would have gotten contaminated from tap water or whatever was on the faucet. And so did dilution with tap water cause the issue? And then I think the other thing is that if you've got a diluted bottle, it means that it's probably getting used longer and by more people. And so there's that increased risk of contamination. But I couldn't find any studies on where people compared, like actually did randomized control and compared diluted and not diluted. We know that animals that had non-diluted shampoos also got it. So I think that there's a possibility that it could occur whether or not it's diluted, but I think all of these things are things to consider. Is the product expired? Has it been used a lot? Are the facilities clean? Is the outside of the bottle clean? It could be anything like that.
Sure. And just lots and lots of people, using the same bottle on lots and lots of different animals, especially like you said, if they just have, and we all want to reduce and reuse. And so you have those dispenser bottles that you're just refilling. But I think from now on, I'm probably going to be taking my own shampoo to the self-dog wash.
Still use their drains. Yeah. Well,
yes, but still use their drains, because that's the part I don't want to do. Well, Dr. Tobias, this has been a fantastic conversation episode. I loved the article. It was great. It was something that I had been familiar with the condition before. So I really do enjoy dermatology, and had at one time, a long time ago, considered a derm residency. So it was something that I was familiar with, but I loved it. It was a great summary. And I encourage everybody to read it. That's the end of our clinical questions. So that brings us to the end of the episode and our Would You Rather questions, which I spent a long time writing because, you've played before, and I wanted to make sure we had some fun questions for you. Are you ready?
Okay.
Okay. You don't sound excited.
Okay, go ahead.
Okay. Would you rather go forward in time and practice 100 years in the future, or go back in time and practice in the 1920s?
Future.
Awesome. Want to see all the great things that come down the pipeline?
Oh my goodness, and new techniques, and somebody will say, oh yeah, we fixed that ages ago. You just put them on steroids, something like that. Remember those perianal fistulas?
Gone.
Not surgical anyway.
If you were attending a party and all of the other guests were talking about their pets, would you admit to being a veterinary surgeon, or would you make up a different profession?
I would admit to being a veterinary surgeon, because then I could plead ignorance.
Okay, to all the medicine questions.
Postgrooming Furunculosis, Don't ask me about vaccines. I don't know what you're talking about. I asked the person down the hallway. I accept my ignorance.
If you could go back and redo your residency, would you rather choose surgery again, or would you choose something different?
Well, if I could choose something where I would be there for shorter hours, would I do it different? No, I would not choose something different. Surgery is so exciting, and it's amazing most of the time to be able to fix something right away. So I can't imagine all these people dealing with malingering problems, and maybe they're not malingering, they're just lingering. But yeah, I kind of like to be able to fix things.
Yeah. Well, I think the veterinary community would be really sad if we didn't have you as a surgical mentor. So, okay, last question. Would you rather have a famous TikTok pet as your patient, or would you rather have a famous Hollywood actor as the client?
Well, I would say that I have had both. And so I would go with the actor.
Okay. Well, I have had neither, but I would also go with the actor. So Ryan Reynolds, if you want to bring your dog in, I'm here.
Sounds good. Obama, I'm here. Well, I mean, he's not an actor, but
No, but still famous, very famous.
All right, Taylor, if you want to come.
If you want to come, it's fine. You can bring Travis Kelce. It'll be great. Okay. All right. That was all my questions. This was fantastic. We can't wait to have you on again. Please write more for us so that we can have more conversations in the future. And all of you at home, thank you so much for tuning in and being part of our Clinicians Brief community. Thank you all for listening to today's episode of Clinicians Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version that we have on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts. Or, if you'd like, drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by me, Dr. Alyssa Watson.